of Medicine for inviting me to do this talk. Now, this is a large talk, and what I thought was I would just give some snippets of what is happening in myeloma or in lymphoma. So I would briefly break it up into biology, diagnosis, and management, and what is currently available in lymphoma. Now, when I was doing my MD, and that's between 95 to 98, and Tambu was my classmate in MD medicine, we had Hodgkin's lymphoma, non-Hodgkin's lymphoma, and in non-Hodgkin's you had aggressive types, non-aggressive types, and you made a decision on how you're going to treat. But over the last 10 to 15 years, with the improvement in molecular medicine, it has been increasingly seen that lymphomas are a very heterogeneous group of disorders. So within, say, a diffuse large cell lymphoma, you still have a large heterogeneous group, all which do not behave similarly with the kind of therapy that you give. And so over the last 10 years, the focus has been in terms of trying to understand the biology of lymphomas and using this biology to actually learn how to treat these lymphomas. So we had these patients who came in with large nodes. You made an immunostaining, you looked for CD20, you made a diagnosis of lymphoma. Subsequently came in studies in terms of FISH to look at specific translocations. But what has probably changed are the molecular tools, gene expression profiling, microarray, and of course using immunohistochemistry to actually define different kinds of lymphomas. Now this has helped in prognostication, in therapy, as well as in understanding disease biology. So if you look over a period of time from the Luke and Collins and Keel classification and the way they have worked out to the latest classification which has come out in 2017, people have used these molecular tools to actually define specific entities. And these entities are ones which would either be associated with very good response, very poor response, or have specific aberrations that define this group of patients. So if you look at mature B-cell lymphomas, you have this large group which has been there for almost 10-15 years, but what people have understood is that now there is something called as an EBV positive large cell lymphoma. Lymphomas in this group are generally not EBV driven except for Burkitt's, but this is now a new entity. And why is this important? Because there are different therapies that you can give. Mature T-cell lymphomas, and I'll come to that, were initially known as anaplastic large cell and nodal lymphomas, but now people have realized there are multiple variants of this, some with good prognosis, some with poor prognosis within this group. So if you look at diffuse large B-cell lymphoma, the first and foremost impact has been with the use of gene expression profiling. And using gene expression profiling, they have looked at different signal pathways and have now clearly come out with two different categories. One which is called as a germinal center B-cell diffuse large B-cell lymphoma, and a second one which is called as non-GCB or an activated B-cell lymphoma. Now, why has this been important? This has been important because this has helped define categories where some will respond and some will not respond to therapy. So people have used gene expression profiling, but gene expression profiling is not available in all centers. So some people have actually used just standard immunohistochemistry, and there are multiple algorithms which have been laid down which would help you in terms of deciding is this DLBCL of germinal center origin or whether it's an activated B-cell origin. So what we commonly use in the pathology here is to use a combination of CD10, BCL6 and MOM1, and we use what is called the Hans algorithm to actually define what is GCB and non-GCB. And why is it important? So if you look here at the GCB versus the non-GCB, using standard chemotherapy, which is a combination of rituximab with chemotherapy, that is a CHOP chemotherapy, you see a wide variance in terms of the response rates. So if you were a GCB, you almost had a 70 to 80% chance of cure, while you were a non-GCB, you dropped down to 30 to 40%. So here you're able to immediately diagnose a group which will not do well with standard chemotherapy alone. Now, this has been replicated. There is data to suggest that the use of a gene expression profiling breaks out these groups much better than what you would see with any of the algorithms, but it still holds true that breaking down into the GCP ABC makes a big important point in terms of distinguishing the diffuse large cell lymphomas. Now, beyond that, what has happened? Now that we have found this group out which doesn't do well, can you do anything about it? So people have begun to look at the pathways that get activated. So the NF-kappa B pathway, the AKT pathways are the ones which have started to be seen in some of these groups. And so what they have tried to do is to see whether addition of additional drugs over and above the standard chemotherapy will help in improving these outcomes. So this is data on combining the R-CHOP with lenalidomide, which is an immunomodulatory drug, and essentially showing that the overall outcomes seem to be better. Randomized trials are on the way. Now we need to wait for these results to actually say whether this will become the standard of care. But the use of molecular biology has helped in not only defining, but looking at pathways and using these pathways to define drugs that would help in improving the outcomes in this poor group of lymphomas. The other thing what molecular biology has also done is to identify within the DLBCL some groups which would even do worse. Now, if you have a CMYC translocation or a BCL2 or a BCL6 translocation, you essentially identify a group within the DLBCL which are called as high-grade DLBCLs. Now, these do very poorly with standard R-CHOP chemotherapy. So if you had a translocation, you called it as a double hit or a triple hit, depending upon whether all three were involved. Or if you had a problem with just expression alone and you had a high expression without the mutation, you called it as a double expressor lymphoma. So within the DSBCL, other than the GCB and the non-GCB, you're also now finding out ones which are actually behave as high-grade lymphomas and so do poorly with R-CHOP chemotherapy. So it's not a separate category, but it is a poor prognostic indicator in diffuse large B-cell lymphoma. And the studies show that with the use of just R-CHOP, this is the other group, and the groups which have got either a CMYC BCL2 or BCL6 double hit, you find that the prognosis has dramatically gone down. So again, here you identify a group which does poorly. Similarly, there was a category which was not Burkitt's, but which behaved similar to Burkitt's, which was intermediate. So it was called as a high-grade Burkitt's-like lymphoma, and now they are finding that giving more intensive chemotherapy, for example, something like R-hyper-CVAD or R-Codoxem seem to be better than using R-CHOP. So the use of molecular signatures have helped in redefining diffuse large B-cell lymphomas into good prognosis, intermediate, and very poor prognosis. So there are a lot of drugs which are being tried out in the non-GCB, lenalidomide, bortezomib, ibrutinib, and of course a transplant in CR1. And in the double expressor, what people are looking is to improve on the outcomes by increasing the intensity of chemotherapy. Now, anaplastic large cell lymphoma, so moving away from B cell to T cell, anaplastic large cell lymphoma was always part of the T cell lymphomas. Now, the standard chemotherapy used is CHOP, and it was always associated with poor outcomes. Roughly about 20 to 30% would improve. Now, what they found was that some of these anaplastic large cell lymphomas actually secreted a protein called as anaplastic lymphoma kinase, or ALK, and then they started segregating or dividing these ALCLs into ALK positive and ALK negative lymphomas. And they realized that the ones who are ALK positive actually did very well with standard chemotherapy. So you had a 70 to 80% chance of cure with an ALK positive ALCL as compared to any of the ALK negatives or the other PTCLs. So this became a focus in terms of knowing what else we could do. Now, similarly, within the ALK negative, people look to see whether this is a homogeneous group or a heterogeneous group. And they found that there is a protein secreted called as DUS22 in which comes through chromosome 6, which is associated with a good prognosis. And so if you were ALK negative, but still DUS22, you could have a reasonable chance of cure with chemotherapy. Now, we need to remember that as we keep intensifying on the intensity of chemotherapy, you are going to introduce more mortality and morbidity. And so the lower chemotherapy that you can give to achieve good success rates becomes very important. So that is why identifying the ALK positive versus the ALK negative, and importantly within the ALK negative, identifying DUS22 helps us in deciding who would continue with just standard chemotherapy alone, or where would you consider intensifying the treatment. Now, in terms of diagnosis, what has played a big revolution is the introduction of PET scans. Now, PET scans have come in probably over the last 10 years, and now it has been important. It's important in terms of staging. But when we are doing staging, we need to remember that all lymphomas are not PET avid. So we need to know which are the lymphomas which are PET avid, which are the ones that are not PET avid, and use it only in those which are avid, because if you get a negative, it does not mean that there is no disease there. But very importantly, what it has done is to help us do an interim PET and actually come down on chemotherapy in patients who have shown a very good response. Importantly, people have shown that if you do a PET at end of treatment and if you're still positive, you do very poorly, and so you need to consider alternate strategies. So the PET scan has become a very important tool in terms of how we manage these lymphomas. Now, I had already mentioned this previously. Molecular mutations and NGS have played an important part in terms of diagnosis, in terms of looking at GCB versus non-GCB and ALK positive versus ALK negative. But along with that, there are some other specific mutations that have been identified. For example, the BRAF mutation, the 600E mutation is characteristic of hairy cell leukemia and is negative in the hairy cell variant. And why is this important? This is important because if you have a standard hairy cell leukemia, you do very well with a drug called as cladribine, while the hairy cell variant will not do well with cladribine, and you need chemotherapy like the other lymphomas. So this BRAF mutation has become a very good indicator of diagnosing and prognosticating. Similarly, in Waldenstrom's macroglobulinemia, the presence of the MDY88 mutation is not only associated with showing that the disease is there, but is associated with a good prognosis. Now, finally, coming to management. Now, all these improvements in diagnosis and prognostication has ultimately to lead to improvement in treatment. And I think one of the biggest revolutions has been the introduction of monoclonal antibodies into the armamentarium of treatment of lymphomas. So from the magic bullet concept, which was raised up by Ehrlich in the 1890s, over a period of maybe the last 20 to 30 years, rituximab came out, which was the first monoclonal antibody in 1997. There have been a series of antibodies that have come out, both for hematological malignancies and for solid tumors, which have actually played a big part in changing the way we treat lymphomas. And the three probably common ones that we use here are anti-CD20, which is basically CD20 is expressed on all B-cell neoplasms. So rituximab is something we use in B-cell malignancies. Anti-CD30 is something which is commonly expressed by Tcell lymphomas and Hodgkin's lymphomas. So we have a drug called as brentuximab, which is used in this group. And a common anti-CD52, which is expressed by all T lymphocytes, is alemtuzumab or Campeth. So it started with rituximab, and there was clear data both in the elderly and young patients that the addition of rituximab to standard chemotherapy offered almost a 20% advantage in terms of long-term cure. This was shown in multiple trials, and so R plus CHOP has become the standard of chemotherapy for diffuse large B-cell lymphomas who are CD20 positive. Now, we talked about the fact that you have a group of patients who have double expressors. So what can we do for them? They have looked at intensifying chemotherapy, and a combination called as a dose-adjusted epoch with rituximab has been shown to be far superior to just R-CHOP alone in the management of these double. So you are able to find a new disease and then you're able to treat it with a better combination which will help in better cure. So our dose-adjusted epoch has become the standard of care for those who have double expressor or double hit diffuse large B-cell lymphoma. CD30 positivity has helped in the use of brentuximab. Now, ABVD is a standard of cure treatment for Hodgkin's lymphomas, and it offers a cure in roughly about 70 to 75%. So the question was whether adding on this monoclonal antibody to standard chemotherapy, exactly like what you would do with R-CHOP, would help in improving the outcomes. Now the data seems to suggest that there is a 10% improvement in outcomes with the use of brentuximab and ABVD as compared to ABVD alone. One of the problems has been that the B, that is the bleomycin, has got pulmonary toxicity, which is similar to the toxicity that occurs with brentuximab. And so people have looked to see whether by taking out the bleomycin from the combination, whether you would get better results. And that is exactly what is seen here, where you have AVD with brentuximab having almost 90% cure rates. Now, I should mention that brentuximab, unfortunately, is a very, very costly drug, unlike rituximab. And so it is very unlikely that in the near future, we will be treating with these combinations, because a course of brentuximab for 6 months would roughly come to about 1 crore. That will be the cost of brentuximab. So we are not going to be using that, but this is the data that is available. Now, we had mentioned the fact that in the CD30 lymphomas, standard chemotherapy had very poor cure rates. So how can we improve on that? So this is the recently published Echelon trial, which showed that if you added the brentuximab, because they are all CD30 positive, to standard chemotherapy, you again had about a 20% improvement. So even in the CD30 positive Tcell lymphomas, addition of monoclonal antibodies seem to help in improving outcomes. People have looked to see whether from the CHOP you can actually increase the intensity, and so people have added on etoposide, which is called as CHOEP, and the addition of etoposide in ALK negative ALCLs seem to have helped in improving outcomes. So for any T-cell lymphoma which is ALK negative and DUS22 negative, CHOEP chemotherapy has become the standard of care. People have also looked at whether we can do an autologous transplant in first remission, and about 50% actually will get cured if you give chemotherapy and then you follow them up with a transplant. Now, there is, over the last 4-5 years, there has been greater excitement, because despite what you do with chemotherapy, about 20 to 30% will still relapse and subsequently die. The only option there would be an allogeneic transplant, but an allogeneic transplant in lymphomas is associated with high mortality, and so people have been looking to see whether there are other druggable targets. So one of them is the programmed death receptor, or PD, which is there on all tumor cells. So this is PD1, and usually you have a ligand on the PD1 ligand, which is there on the tumor cell, and the PD, which is there on the T lymphocytes. Now, this binding of the receptor to this ligand blocks off killing of the tumor cell. So it's got an inhibitory function. So if you can block this receptor, then you can actually cause killing of tumor cells. Now, this can happen with both hematological and solid tumor malignancies. There are two drugs that are available, nivolumab and pembrolizumab. And essentially, it has been used in relapsed refractory disease. So this is a group of patients who have failed an autologous transplant or failed a combination of autologous transplant and brentuximab, and failed probably both together or in combination. And essentially, they showed that single agent nivolumab improves in about 70%. And roughly about 20 to 30% actually will get a complete remission. So this is a new drug which has come in. It is not as costly as brentuximab, so it's much cheaper to use. But one of the ways that it can be used is somebody who has a relapse, you can use it instead of chemotherapy to induce remission and then take them up for an autologous transplant also. The other, which is group which is probably causing a lot of excitement, at least abroad, is the chimeric antigen receptor or the CAR T cells. Now, what is the CAR T cells? Essentially, you have an antigen on the tumor surface. This could be anything. You will have a receptor on the T cell, and you put this construct in which will bind to both the T cell receptor, usually through CD3, and bind to this antigen. Now, depending upon what it is, so if you have a leukemia, you can actually put in a CD19. If you have a lymphoma, you can put in CD20 into that construct. If you have a myeloma, you can put in CD38. So depending upon what the tumor cell expresses, you can put that construct. So when you put that construct into the T cell, you make lots of T cells, and then you put it back into the patient. They will go and seek out these receptors, bind to these receptors, and cause severe tumor killing. Now, the problem is this is associated with a lot of cytokine storm, and so there is a lot of cost that is involved. At present, the cost within the US is about $500,000 for the CAR T cells, and about $500,000 for the supportive care. So we need to remember, but people are working on different modalities where they're trying to bring this down. But the responses are really dramatic. So this is one of the published data in NEJM where they looked at patients who are refractory, and refractory means these are patients who have failed at least 4 to 5 lines of therapy, including an autologous transplant, exposure to multiple monoclonal antibodies, and essentially they showed that in 100 patients, an objective response in 80%, a complete response in 50%, and many of the responses are actually going on for a period of time, which means that they are potentially cured. So those who have completely cured, if you look over a period of about 16 to 20 weeks, they are completely cured. Now, we will not see this with any other therapy that is available. We still need to see long-term follow-up to see whether these would fall off, and so whether the patient relapse back. But this is essentially non-chemotherapy regimens which are available for treating. And then I will just show you. So this is a patient with a large lymphoma. This is part of the trial, and with just 12 months after a single infusion, most of it is gone. Sometimes you may do 2 infusions. So this is before the infusion, post first infusion, post second infusion, and that is all that is required to actually kill the tumor. So I'll stop by saying that a lot of progress in understanding the biology of lymphomas has led to the identification of specific entities. And I think it's very important to identify them correctly because they have variable prognosis. We see a lot of patients who have been diagnosed of DLBCL, nothing done beyond looking at what kind of DLBCL, treated outside, and when they come after failure, it becomes more difficult. We need to remember that the best therapy is the first therapy that you give. So it's very important that we identify the tumor properly before you actually decide which is the best therapy for that patient. PET scan is an important tool in the diagnosis, staging, and management. The use of monoclonal antibodies has revolutionized the management of lymphomas, and CAR T cells and PD-1 inhibitors are the future of non-chemotherapy treatment. So abroad, people are looking to see, instead of chemotherapy, can we just give CAR T, or whether we can give PD-1 inhibitors to just treat the tumor. With this, I'll stop and I'll be happy to take questions.